much. So just a minute. Okay. So today is, you can say, the topic is role of gynecologists in thalassemia prevention. And since the government of India has a ambition mission to have anemia mukt Bharat, and though it includes all the four types of anemias, there is iron deficiency anemia, pernicious anemia, aplastic anemia, and hemolytic anemia, and but there is still focus on hemoglobinopathies as well. So, as far as hemoglobinopathies are concerned, this is commonly known as thalassemia syndrome. It's a serious inherited blood disorder presenting in severe anemia. Its formation of adult hemoglobin is absent, inadequate, or abnormal. And the life of red blood cells, which is normally 1 to 10, it is shortened to 15 to 20 days only. It is caused by either a genetic mutation or a deletion in a certain key genes. And inheritance of thalassemia is autosomal. It can be alpha thalassemia, beta thalassemia, sickle cell anemia, HBE, C, D, Q, or various permutations and combinations. Adult hemoglobin is hemoglobin molecule is formed by a symmetric pairing of alpha and beta globin chains with iron porphyrin molecule in the center. In thalassemia, synthesis of either alpha or beta chains is reduced, resulting into shortened survival of RBCs, leading to severe anemia. Alpha thalassemia is of two types, alpha 0 and alpha plus. Alpha 0 is severe variety, and homozygous alpha 0 thalassemia is not compatible with survival and is known as HB Bart's hydroxypetalase. Alpha plus is milder and its inheritance is of not much importance individually, though it has effect with beta thalassemia. In India, alpha plus is very common. In beta thalassemia, there is defective synthesis of beta chains, and the manifestations are due to excessive alpha chains. Since in our country, beta thalassemia is very common, so when we say thalassemia, it is almost understood as beta thalassemia. So when the child is born with beta thalassemia major, child is absolutely hale and hearty, and by the age of 2 to 4 months, 6 months, or 8 months or so, child becomes pale, anemic, lethargic, loss of appetite, delayed milestones, and at that time, if we don't diagnose, you can have protruded abdomen because of increase the size of liver and spleen. You will see the malnourishment, or even this facial bones are protruded. So typical thalassemia phases are there. 90 to 95% thalassemia major are diagnosed within first 2 years of life, and 2, 3, or say 5% at any time, maybe at 3 year, 5 year, 10 year or so, they are thalassemia intermediate. The basic treatment is repeated blood transfusion every 2 to 4 weeks, and repeated injection, hospital visits, higher insulation, cost of therapy 50,000 to 2 lakh per year, and the permanent cure, the bone marrow transplantation, which is feasible only when we have 100% matched HLA donor available, which is only 25 to 30% within the family, say with siblings, 1 to 2% with the parents, mother or father. In public, or you can say unrelated donor, it is 1 in maybe 1 million or 10 million, depending upon the registry of that particular country or that particular group. There is always a fear of transfusion transmitted infection like hepatitis B, C, and HIV. You can imagine the life of a thalassemia major child, loss of time, energy, money, endocrine complications, liver, puberty failure, heart failure, and always having a fear of early death. So this is a story of a 35-year-old thalassemia patient who has already taken 1,000 units of blood, 20,000 injections of desferal to take out iron from her body. She had already 90,000 hours of injection in her blood, because in this case the injection is not given like tetanus, B complex, or any other injection. It is given by slow IV, slow subcutaneous infusion with infusion pump for around 12 hours a day or night. She has already spent 40 lakh rupees on the desferal therapy. She could afford because of her father was a CGHS beneficiary. We expect her to live for another 30 years. In that case, she will require another 1,000 units of blood, 20,000 of injection desferal, 80,000 hours of needle in the body, and more than rupees for the testosterone therapy. Thalassemia is not a disease of people. It is not a rare disease.
Please mute yourself. Please mute yourself.
It's a 50 million, that is 5 crore Indians are thalassemia carriers. And the most important is the most famous celebrity Amitabh Bachchan is a thalassemia carrier. I always quote him because reason being, see, he is known by everyone. Everybody knows who's the Amitabh Bachchan. He is 6 feet 2 inch tall. He's 82 years now, and at this age, he's much more active than us. A person like him, who is 6 feet tall, 80-year-old, and active, can be thalassemia carrier. Then why you and not me? So this is the message I give everywhere in every public speaking. I have other examples as well, but this is the most common one. So how common it is? Around 1 to 17%, average 4% Indians are thalassemia carrier, and more than 12,000 new thalassemia major births take every year in our country. Sickle cell, which is quite similar to beta thalassemia, it is very common in tribal areas like Madhya Pradesh, Chhattisgarh, Odisha, Gujarat, Maharashtra, and around 17 states are it is very highly prevalent, and some areas it is 40%, as high as 40%. HBE is more common in West Bengal and northeastern states, and countries like Southeast Asian countries like Thailand, China, Singapore, all these countries is very common there. One thalassemia major is born every year in 45 minutes. One thalassemia major child is born every 45 minutes in our country. So this was a study done all over India, where it was found that it is very high common in this northeastern states, which is not states like 3 to 10% in Punjab, Delhi, Haryana as well. Around 2.5% the west. It's very low in the south, 1 to 3%, the Karnataka, Tamil, Andhra, Odisha, etc. And around 2.4% West Bengal, and north is 1.1 to 3%. This is another study done at the 6 centers on 21,645 cases and 10,000 students and 10,000 antenatal cases. Again, it was found to be 2 to 4% in various communities. In Ahmedabad, Gujarat, and around 1,42,000 pregnant women were screened, and about 6,271, 4.3% were carrier. Out of these females, only 5,814 husbands came for the screening, and 6.75% couples were thalassemia carriers, and 92 thalassemia major birth could be prevented. So, as you all know, it is an autosomal recessive inheritance disease. Where if both parents, husband and wife, have one thalassemia gene, and whenever a child is born, it takes one gene from one parent, one gene from other parent. If child takes both normal genes, child is absolutely normal, better than parent. One abnormal and one normal, then thalassemia carrier like parent, 50% cases, and 25% if child is taking both abnormal genes and he has to survive on repeated blood transfusion. If one of the parent is a carrier, then no child will be thalassemia major, 50% child will be thalassemia carrier, and 50% normal, because no child will have two abnormal genes. So prevention is the ultimate cure. So why it is required? You have seen that it requires lifelong repeated blood transfusion, lifelong hospital visits, lifelong costly treatment. There is a limitation of permanent cure. Even if you have a HLA match donor available, in that case it costs 15 to 20 lakh rupees, and the treatment is very risky. During that 3 weeks period, the patient is prone to even more common opportunistic infections. The cost of treatment is 1 to 2 lakh per annum, and ignorance in public is very common. As I told you, even medical professionals, though we can see now it's much better in Delhi and other metropolitans and big cities, but still smaller cities, nobody is aware of what thalassemia is. They just know it's okay, it is a just blood disorder, and it is preventable, so it should be prevented. I'd like to show a small video.
हमें पता हमें तुरंत थैलेसीमिया के बारे में हमें पता भी नहीं था। वही 3-4 महीने से हमें पता चला है कि मेरे बच्चे को थैलेसीमिया हुआ है और मैं तब से लेकर आज तक 3-4 बार फोन करवा चुकी हूँ अपने। मैं नहीं चाहती हूँ कि किस तरह से मैं अपने बच्चों को लेकर परेशान हूँ, इधर उधर भटक रही हूँ। इस तरह कोई और माता या पिता को बच्चे को ऐसा बीमारी ना हो, उस तरह ऐसे मतलब लेके नहीं भटके, उसको सुनने ना लगे। मैं चाहती हूँ कि ये वीडियो मतलब हर जगह मेरा ये पहुँचे कि सबको थैलेसीमिया बीमारी के बारे में जानकारी हो सके, क्योंकि इससे पहले हमें थैलेसीमिया बीमारी के बारे में कोई पता नहीं था। अगर डॉक्टर ने हमारे प्रेगनेंसी में थैलेसीमिया का जांच किया होता तो आज हमारे बच्चे को ये थैलेसीमिया बीमारी नहीं होता। मैं अपने बच्चे को लेकर ऐसे नहीं भाई, इसलिए मैं चाहती हूँ कि जिस तरह से मेरे बच्चे को हर महीने खून चढ़ रहा है लेकिन जब तक भटक रहे, ऐसे किसी भी बच्चे को ये बीमारी ना हो, खून ना चढ़े और सुइयां ना लगे।
You can imagine the trauma of this family where they have to go for repeated blood transfusion from Bihar.
Dr. Sudha Rustagi, kindly mute yourself.
As I told you, thalassemia is preventable. Already, we can give the examples of few countries like Cyprus, Sardinia, Greek, Italy, and Thailand. Cyprus has the highest thalassemia carrier rate. It is 17%. In India, it is 4%. In Cyprus, it is 17%. They started a prevention program in 1974. Within 10 years, by 1984, it reduced to almost zero. Same story is with the Italy, Greek. They could control the thalassemia within 10 to 15 years. And the most successful plan included the carrier detection, counseling, and fetal diagnosis. How to screen thalassemia carrier? So actually, it is very easy to suspect thalassemia carrier status on CBC. Nowadays, CBC is available in almost every, even government lab, district lab, private center. So we have CBC cell counter over there. Instead of just looking at HB, TLC, TLC, platelet, etc., if we look into MCV and MCH, if MCH is less than 27 and MCV less than 80, we can suspect the person can be or maybe a thalassemia carrier. And if we just look again on RBC count and hemoglobin level, if hemoglobin level is lower than the RBC count, means suppose normal hemoglobin level is 12 to 16 and the RBC is 4.5 to 5.5. If we see hemoglobin level is 10 and RBC is say around 4.5 or 5, it is much higher as compared to hemoglobin level. Or you can say HB is say 13 and RBC is say 5 or 6, then it is again looks to be very high. So if you see hemoglobin level is lower compared to RBC count or RBC count higher compared to HP level, so that indicates it may be a thalassemia carrier status. And RDW is mostly normal or slightly high, high only when there is another addition of a iron deficiency anemia. So there are few different factors where we can suspect by looking at the CBC, that is Menser, Chinal, England Frozer. Though England Frozer is used very commonly, Menser you see MC by RBC if less than 13, it is thal minor, more than 13, it may be iron deficiency anemia. But none of these is so robust, you can say. We cannot fully rely on this. So final diagnosis is HbA2 estimation, which is done by either HB electrophoresis. Nowadays, we have HPLC, which tells you everything in one go. Even HPD, SE, all these things, they can be diagnosed in tests of HPLC, which is very fast and reliable. See, if HbA2 is more than 3.5%, so the person is a thalassemia trait. But in the further 4-5 slides, I like to your extra attention because HbA2 may also deceive you. Here, as you can say, Dr. Sharda Jain said, okay, when this test needs to be just once in a lifetime, why not to get it done at the time of say 2 year, 3 year, 5 year, as early as possible, so the person understands what is his thalassemia or her thalassemia status and take preventive steps as and when getting for married or planning for the family. So this is how HPLC reports look like. So as told earlier, anemia is not a criteria to diagnose, you can say, thalassemia carrier status. See, you have to look into this MCV and this the MCH. If MC less than 80 or MC less than 27, the person may be thalassemia carrier, even if the hemoglobin level is very high. Maybe even 13, 14 in the 15 up to in the males and maybe 12, 13 in the females. I'll show the real example which we did at our center. You'll see the hemoglobin level is 13 gram, RBC count 4.74 millions, MCV 79.4, just borderline. One may say, okay, it's at 80 and 704 is almost same. So 1 minute ask for this HPLC test. And again, looking at MCH, it is 27.5. That is very much normal. Even though these parameters are quite near normal, but what we found is HbA2 4.3 and HbE 19.7. So that person is a HbE trait. So never miss even a borderline case. Even just suspecting slightly, ask for HPLC test. I'll show you another example. Here again, hemoglobin is 15 gram. Here you can see RBC 7.07, very high as compared to hemoglobin level. Here MCV and MCH are low, and you see HbA2 is 5.4. If we just look at hemoglobin level 15 gram, one can say, okay, no need to go for HPLC, but the person is a thalassemia carrier. So again, repeating, anemia is no criteria to diagnose thalassemia. So problems with hematological screening are as follows. Say in beta thalassemia, some atypical and silent beta thalassemia may be missed when HbA2 is less than 3.5. Silent mutations have normal or only slightly reduced MCV and MCH values. Delta beta thalassemia has a raised HbA2. It is still easier to diagnose delta beta thalassemia because in adults after age of 1 year, you can say, when a child becomes age of 1 year, fetal hemoglobin is less than 1%. If it is more than 1% and it is not giving any HbA2 other, so then we can look for delta beta thalassemia. For alpha thalassemia, there is no specific screening. It can be tested only by genetic mutation. So, but by HPLC, the diagnosis is made by the exclusion only. Alpha 0 thalassemia have occasional red cell containing HbH inclusion on peripheral smear. Definitive diagnosis between alpha plus and alpha 0 is done only by DNA analysis. The HB variants like HBS, D, and E, etc. Only abnormal hemoglobin that can be identified definitely without restoring to molecular analysis are HBS and other sickling variants. For others, you may have to go for DNA analysis. A person who is carrier of both beta and alpha, it may have normal MCV and MCH values and because of less globin chain imbalance. Because if they are combined, there is less imbalance, you will see normal MCV, MCH. In alpha plus, that is if at all only one allele is missing, the carrier may have normal or reduced MCV and MCH. So high RBC count and low MCH and MCV is seen besides beta thalassemia, also in alpha thalassemia trait, homozygous, that is minus alpha, HbH disease, HbE trait, HbE homozygous, and HbD homozygous. Fallacies in HbA2 estimation. If there is additional iron deficiency, it lowers HbA2 level. Silent BTT may not have elevated HbA2 levels. Coexistence of alpha thalassemia may have normal level, as I told you earlier, and same way delta beta thalassemia may have normal or low level of HbA2. Iron deficiency also complicates the diagnosis. Severity of anemia will be disproportionate to the HB variant. Quantity of HbE will be low in E trait, A2 will be low in beta trait, and Q will be low in Q India trait. Normal HbA2 can be seen in beta thalassemia trait. In fetus stage, in neonates, infants, iron deficiency anemia with alpha thalassemia, or if there is beta gene locus control region deletion, and in mild beta thalassemia mutations, silent beta thalassemia, or also in delta beta thalassemia, HB lipo. In both these cases, you will find increased fetal hemoglobin. False HbA2 rise can be seen in HbSS Indian Saudi Arabia variant, S beta, SS, and alpha thalassemia homozygous. It is because of glycated HbS or due to high affinity of alpha globin genes for delta globin genes. Formation of HbS adults which have the same retention time as that of HbA, because they travel at the same time which the HbA2 travels. So this creates a diagnostic problem. So how to interpret HbA2 level? If it is less than 3.1, it may be normal or alpha thalassemia trait. Especially if it is less than 2, then suspect alpha thalassemia trait. If it is between 2 and 3, most probably it will be normal. 3.1 to 3.9, it is beta thalassemia trait with iron deficiency anemia or interaction of alpha and beta thalassemia. 3.9 to 9 is beta thalassemia trait, and more than 9 is HB lipo, E syndrome, and D ERA. So, if one partner is thalassemia carrier and other is borderline HbA2, say 3.1 or 3 to 3.5, mutation analysis of genes by gene sequencing should be done. If one is carrier, do not forget to undergo gene sequencing for the partner. Here another example, if you see borderline HbA2 levels in beta thalassemia, just see here A2 is just 3%, and you see out of 11, 10 are beta thalassemia trait. This is the trait, this is normal. Just see 3 gram only, 3% A2, and 10 out of 11 are thalassemia carrier. At 3.1 also, 4 out of 5 are thalassemia carrier. So even though low levels of HbA2, you should not miss a thalassemia carrier status. Again, here another example. MCV more than 80. So 10 are HbA2 level 3 to 3.2. MC is more than 80. We are saying 80, less than 80, and it is more than 80. As you see, 10 are 3 to 3.2, and 10 patients 3.3 to 3.5. Same way, MCH. Generally, we say it should be less than 27, but it is more than 27, and you see 5 are having 3 to 3.2, and 12 are having 3.3 to 3.4. So at least borderline case should not. If there is slightest of the suspicion, then you must go for gene sequencing. No, never miss. So what is the significance of borderline HbA2 levels in beta thalassemia? See another study. 20 out of 149 beta thalassemia carriers showed HbA2 less than 3.5% and MCV more than 80. See, out of 149, means out of 150, 20, it comes to 13.5%. They are thalassemia carrier in spite of having A2 less than 3.5 and sorry, and MCV more than 80. So it's very important thing. Borderline HbA2 levels are one of the cause of misdiagnosis of beta thalassemia carrier. An interaction of alpha, delta, or iron deficiency anemia in beta thalassemia heterozygotes as a cause of borderline HbA2 level is not uncommon. So HbA2 levels, MCV and MCH levels fail to predict heterozygosity for beta thalassemia and thus could lead to misdiagnosis of carriers. We strongly suggest that a comprehensive molecular workup of beta globin chain should be performed when borderline HbA2 levels in combination with normal or subnormal MCV and MCH values are encountered in routine laboratory setting. In cases where one partner is a carrier of the hemoglobinopathy, this will not only reduce the false negative results but also reduce the burden of thalassemia in the future. This is very important slide because tomorrow you may not get into trouble because of you are not going for sequencing. So if you screen at the early age, pre-marriage, so said 5 year, 10 year, 12 year when the girl comes to you, so you have to tell them it is carrier state is a no disadvantage, a risk only when your partner will be carrier. And if your partner is a carrier, you can have a thalassemia major child, and fetal diagnosis is available and safe. This is the message. This is again a flow chart for carrier screening. Here we say, because though they have said 78, but we say 80. And if there is a normal, you can say high, this MCV and MCH, but A2 and above low, it may be normal, but it may be silent beta thalassemia trait as well. So this is common, but we usually see beta thalassemia. In this case, it is both low HPA2 is low.
Dr. Vandana,
Please mute yourself.
mobile mute करिए.
Please mute yourself. Okay. It can be either alpha thalassemia trait or delta beta trait or delta beta thal trait. So same way, if these are flow chart, because very complex one. Okay. Now what we should do? The screening of pregnant woman on very first visit. That is the most important. The moment you see UPT positive, advise HPA2 or HPLC. Screening for RBC and DESI positive confirmed by HPA2. Electrophoresis of the partner. If husband is normal, not PTT, no action required. If husband borderline, go for husband mutation. Is husband found beta thalassemia trait? Need for prenatal diagnosis. If fetus major, can go for termination, and normal or carrier continue the pregnancy. So there are more than 200 mutations world over, but every community has some common mutations. So in India, we have these 5 common mutations: IBS1, 5, 16, 619, BP, IBS1, etc. And these are the 5 uncommon mutations. So what are the indications of partner screening for prenatal diagnosis? If the female coming to you, if she is beta thal trait, delta beta trait, S trait, E trait, D trait, or D thal or Q thal, the partner should be tested. And prenatal diagnosis is required if both are thalassemia trait, one beta trait, HBE trait homozygous, one B trait, other sickle trait, both sickle and HBD trait homozygous combination, or delta beta thal combination, and delta beta and beta thal combination. All these cases require prenatal diagnosis. Prenatal is not required if both partners are HBD trait or homozygous, both are HBE trait or homozygous, and one partner is Q India and other is beta thalassemia trait. But here I like to add one more thing. You must see that if at all, I told you HBD trait with the D homozygous is not required. But if at all both are D trait, you should also look for the beta mutation, because maybe one person, the female coming to you is a D trait and husband has beta and D. So then beta, or you can say sickle, then sickle and D will be a serious combination. Same way, if both are E and one of the partner has a E beta, and then that beta E will again have a serious complication in the child. So look for the genetic mutation as well. So here is a one case where you see HPT 32.3 and other is 36.3. So in that case, HPDD no PND not required, but HPD beta thal PND not required, but confirmed by DNA, check for beta thal mutation if red cell indices suggest of thalassemia carrier status. Another example where you see husband is a heterozygous for HBE and wife is a homozygous for HBE. In that case, again, E heterozygous and E homozygous PND not required, but E and beta thal mutation prenatal is required. So 3 major steps: DNA extraction, mutation analysis in the family, microscopic dissection of CVS, look for pain mutation, and reporting within the 7 to 10 days. So, though it is a your domain, but I like to stress that for every pregnancy, there's a fresh sample of the consecutive pregnancy should be taken for the mutation analysis for the family, parents and the affected child. So here it is another important message there. Providing resources for the treatment of existing patients is not enough. If numbers increase each year, with the birth of more affected children. In addition, with adequate treatment, the rate of patient survival increases, and there is thus a cumulative increase in patient numbers to be provided for adequate treatment. So, according to WHO, the annual cost of a nationwide prevention program in most countries equals to cost of treating one annual birth cohort of patients for जो एक बच्चे को एक साल में ट्रीटमेंट का खर्चा आता है उतना आपका पूरा you can have a prevention program of the country. So this is, you all know much better than me how to go for period diagnosis. This is a cost. Again, you may be knowing at LNJP it is free, at AIMS, SGPJ, Lucknow, PJ it is 2,000 to 4,000. Private it may range from 15,000 to 30, 40,000, and PGD 3 to 5 lakh rupees. So 95 it was diagnosed. The first case was diagnosed. 1970 pre-diagnosis developed. 1990 in India had a facility for prenatal diagnosis, but still in 2012 we have patient, not 2012, I say even 2024, we are still having new patient being born with thalassemia major. So these are very pretty children. You see, everybody likes, but we don't want they to be tied with the blood bags like this. So take home message, you all know, I have repeated it so many times. Don't forget to add HPLC in your test list. Advice to pregnant on very first visit. That is the most important message. And again, I'm sorry to say, but it is true that whenever a thalassemia major is born, family starts cursing obstetrician, as you have seen that video as well. So this is, we are having a thalassemia camp. We have also started a thalassemia screening program. And
थैलेसीमिया रोग एक गंभीर अनुवांशिक रोग है जिसमें बचपन से ही हर महीने खून चढ़ाना पड़ता है। इसका इलाज बहुत महंगा एवं दर्दनाक है, जिसका खर्चा लगभग 50,000 से लेकर 2 लाख रुपए सालाना आता है। इसकी रोकथाम संभव एवं आसान है। थैलेसीमिया माता-पिता से बच्चों में आता है, जो दिखने में हमारी आपकी तरह स्वस्थ दिखते हैं। भारतवर्ष में 5 करोड़ ऐसे स्वस्थ थैलेसीमिया कैरियर हैं जो पति पत्नी के रूप में थैलेसीमिया बच्चे को जन्म दे सकते हैं। यदि गर्भधारण से पहले अथवा गर्भ के आरंभ में ही अपनी थैलेसीमिया कैरियर की जांच करा ले तो आने वाले बच्चे में थैलेसीमिया रोग को रोका जा सकता है। नेशनल थैलेसीमिया वेलफेयर सोसाइटी एवं जेकर फाउंडेशन दिल्ली एवं एनसीआर में थैलेसीमिया खत्म करने के लिए वचनबद्ध है। आइए हम सब मिलकर भारत को थैलेसीमिया मुक्त बनाते हैं।
So it's a teamwork, and a special support is requested from our honorable gynecologist. एक बार फिर मैं आपसे यही चाहूंगा कि आप हर वर्ष 8 मई को शपथ लें। मैं कभी भी थैलेसीमिया बच्चे को जन्म में कारण नहीं बनूंगी एवं अन्य चिकित्सकों को भी इसके लिए प्रेरित करूं। धन्यवाद। थैंक यू।
Thank you, sir, for an excellent deliberation, an excellent message. So, in practically all the cases, you would say any HbA2 level above 3, we
Yes.
should be suspicious.
Yes.
We should be suspicious. Yeah. So, I would ask my expert.
Especially the partner is a carrier.
Yes.
You
Yes.
see, partner is having 2.5, 2.3, you can still forget it.
Yes.
If it is partner is a carrier and one of the partners is having 3.0 plus, must
Right.
go for genetic mutation.
Okay. If both the partners have somewhere around 3.1 or 3.2,
Oh, sure.
then
Still.
still
Yes.
we go for genetic mutation
Yes,
test.
yes.
Okay, thank you. So Dr. Deepshika has raised her hand. Before taking the comments, I'll ask her. Dr. Deepshika, unmute yourself and ask your question. So So she seems not to be around. So Dr. Deepika, would you like to comment on it, ma'am?
Yes. So again, I learned something new, not new, of course, but we've never been deliberating on the borderline A2 levels.
Right,
So
right.
I think this is something which we need to see, because we often get reports of 3.2,
Yes,
3.4, and of
yes.
course we always do the genetic further testing. But this is something which everybody should know, that we can take the cutoff so that we can increase the chances of actually catching
Detection,
children with
detection.
thalassemia trait, and so that the birth of a baby with thalassemia is prevented. So I think we should really go to the schools, which is a new idea from this CME, along with the blood group, the thalassemia done in schools. I still remember
Yes,
we were talking many years back about going to colleges and doing, and then people really objected at that time.
right.
Uh,
No, but that awareness, there has to be an awareness talk, I would think, beforehand when we offer the test. So they should be like my patient was scared. ये बढ़ जाएगा, ये क्या disease है? What is it? What you have found out? Is it something very major? The scare is there. They are not aware of what it is. So I had to
Yeah,
pass it
so I
on.
think we should write in newspapers and
Yes,
radio talks and all that. I
right.
think we should have more awareness drives.
Awareness has to be there.
we are
Awareness.
trying our best. I need your support. If at all any of you may be having links with some principals, some senior teachers of even
Right, sir.
colleges, you can just link us because we are now doing blood rich camps in with free thalassemia screening. So we
Thank
are
you,
doing
sir.
even blood rich camp. We are doing screening free over there, and even in all, it's open offer to all of you. Every second Sunday we have a thalassemia clinic. If at all any person say any problem in because of cost is or she's not going for testing, it is free of cost available with us on you can say second Sunday of the month. So I can give you the. I'll just write the phone number of the in a chat box or note down. It's very easy. 93
Yes, sir.
for any information on
Yeah, you
thalassemia.
give me the number.
Nine
I'll put it in
three.
the group. Yeah.
Yes. 93
Yes.
111
Yes.
66
Right.
711.
711. So this is thalassemia clinic.
Yes. It is our office number, and if at all anybody wants any information
Right.
or even for free testing, and we have second Sunday we have free
Okay.
testing.
Okay.
As Dr. Deka said, my 2 days test was more on borderline cases because I had seen now many cases missed borderline. One thing more, I recently came across a case diagnosed thalassemia major. There you can say report of the female means the pregnant woman was written as thalassemia carrier. Though she had advised HPLC, it was I saw on the prescription. She advised the subsequent visit HPLC and it was the husband. But the patient did not got it. When he asked the patient said, I was not told. So there was some miscommunication. That means though the gynae wrote it on the prescription, but somehow it was not clearly communicated and she did not ask next time, where is the report? So she said, I was going to that clinic regularly, but I was not even asked the second time. If at all I have not got it done, I was not asked the report. So though it was advised, because of this communication, it was not tested. So please, this also to be looked into by looking.
Okay. Okay, sir. At times it happens that the patients are so worried about so many things. The doctor counsels, says, but they don't register. So you just need
Yes,
to ask them, okay, what has registered to you.
Second time, what's the report? Yes. Yes, madam, Dr. Deepika.
Yeah, Dr.
Though this was not covered in your talk, another problem faced by thalassemia patients and obstetricians is the pregnancy. The thalassemia patients now want to become pregnant, and you have sent me 2 patients who are so educated, they're willing to do anything. So I think, Dr. Arora, you should go and talk about this surrogacy. Because these are thalassemia women who want to become pregnant. And from your side, if you go on, to the government and talk that these are the indications for Ritu, the patient from Meerut, she called me up and she said she has won the case. Okay, but the problem is you have to go to court, spend so much money, get the permission and all that. So I think from your welfare society, for the thalassemic women, we must have surrogacy allowed.
Very good idea, madam. Thank you very much for
Thank you,
reminding
thank
me.
you, thank you.
Though I had, because some patients told me, it's good idea that you asked me to go for this. We'll certainly go for it. Thank
Right.
you very much.
Dr. Deepchika, you raise your hand. You ask your question.
Take
You are not
comments of the
audible.
chairperson, please.
Okay, okay. So I invite the comments from the chairpersons. Dr. Renu Misra, are you there, ma'am? I saw Dr. Renu Manchanda was there.
Yeah, I'm there.
Yeah, Dr.
I
Renu.
think, as Dr. J S Arora has highlighted, that thalassemia is one of the prevalent genetic disorders. And in India, because it is very prevalent in Delhi, where we are all practicing, especially in Punjabis, Gujarati, Sindhi, and we come across these patients during our antenatal patients very commonly. And sometimes the consanguineous marriage, which is also customary in many of these societies, the expression of this autosomal recessive life is also high, and so we are likely to, have babies born with thalassemia major disorder. So, as recommended, universal screening program for thalassemia during the antenatal period is highly recommended. And I would like to share that we have already started universal screening in government setup. What we used to do that during the first antenatal visit, we were doing CBC with RBC indices, and if the RBC count is high and MCV is low, like we are doing the menstrual score, if it is less than 13, we were screening for the thalassemia by HPLC with HbA2 level. Now there is a paradigm shift that we have started screening irrespective of the CBC indices. We are screening all the patients with HPLC test.
एक मिनट अपना बंद करना है फोन में अपना कनेक्ट कर देता हूँ फिर
Hold on.
And
Dr. Manju Agarwal, I request you to kindly mute yourself. Yeah.
And if the screening test is positive, we are advising screening of the spouse also. And if the screening is positive for both, and if we all know there are 25% chances of getting a thalassemia major baby in such cases if both are carriers, then we would like to confirm the diagnosis first and then advise uh, diagnostic testing for the baby, either by chorionic villi sampling or amniocentesis, depending upon the period of gestation. And if we screen early during the pregnancy, like about around 8 to 10 weeks, which we are routinely doing, we find that we have sufficient time for workup and counseling of these couples, and also for plan their pregnancy regarding the termination of pregnancy or whatever this thing. So I advise that early screening for thalassemia on the first antenatal visit, preferably about 10 weeks, 10 to 12 weeks of gestation. It should be done for all the patients, irrespective of the hemoglobin level. And if hemoglobin A2 and the screening test is positive, then we go ahead with the diagnostic test to prevent the birth of a thalassemia major baby, because thalassemia major has a great psychosocial and financial burden on the family. So this is the message I would like to give to all the obstetricians, that whenever we are getting the CBC report, we should look at MCV, we should look at RBC count. That gives an indication that okay, this may not be an iron deficiency anemia, this is a thalassemia trait we are dealing. Because I know of a patient who was being treated in my own hospital. She was diagnosed as microcytic hypoproliferative anemia, depending on the peripheral smear, but she was given the iron therapy, but because she was not responding, later on she was screened, she was found to be thalassemia trait, and giving iron to these patients is, very, very risky, because there is iron overload in these patients, and that is not highly desirable or recommended.
Thank you, ma'am. Thank you.
Where
Dr.
are you, madam? Dr. Renu Manchanda, at which center you are?
I am working in Chareshri Dikshu Hospital. I am senior consultant obstetrician and gynecologist, and I am in a government setup, and I am practicing there for last 30 years. And we have very commonly, we were doing it like all the patients who are coming with microcytic hypochromic anemia on peripheral smear, it was taken as iron deficiency anemia. But now, because of the awareness that we are practicing in an area which has high prevalence for thalassemia, carrier state thalassemia trait, we are now screening each and every pregnant woman who is coming to our hospital for antenatal on the first visit by doing HPLC test.
You have HPLC machine, madam?
We are sending the patient, we have a tie-up, and there is a pilot study going on by the government of India. A person comes from LNJP hospital, he collects all the samples of HPLC on the first visit, and we get report from there.
Okay, fine.
Thank you, ma'am. Dr. Leena Sridhar, I can see you. You are there. Yes, ma'am. Carry on.
Dr. Kullar is also there. Yes.
Yeah. I'll call Dr. Leena Sridhar. She is there. I saw her. Dr. Harsha Kullar, if you are there, ma'am. Dr. Neeta Rajoria.
Yeah, I just want to reiterate what Renu Manchanda ma'am has already told. Our hospital has also tied up. Our samples on antenatal days are going to Medical College. So we screen them through indices also, but HPLC we are doing. They have, lies with us. They collect the samples, but it is done only for antenatals at present, because it is something very serious. And thanks to Dr. J S Arora sir, sir has highlighted the relevance and importance of doing the test. I always narrate this story to all my friends. My own colleague, ophthalmologist, she got married. It was a love marriage. The husband was also ophthalmologist. They were blessed with a male boy. A boy was there. But, as sir has highlighted, initially the baby was all right. But then the hemoglobin started dropping. The baby started becoming pale. And when investigations were done, to their utter surprise and dismay, the child was having thalassemia majors. And these unfortunate stories keep on happening. So it is very relevant for obstetricians to be themselves aware the seriousness of the situation. We should not have any thalassemia major baby born. And as madam has told, we have got some screen positive cases also, and some variants also have been detected in our few of the patients. When we get confused how to counsel these couples, we are sending them to the same LNJP hospital. They counsel about other variants also. So
Thank you, Dr. Anita. Dr.
that
Leena.
is all I want to add in this.
Dr. Leena, you're welcome.
Yes, hello.
Yes, we can hear you.
So the volume thoda zyada kare. Yeah. So I've been hearing very intently, and thank you very much for having me here, Dr. Vandana and Dr. Arora. This is the second time I'm hearing you, and for so many of us, it's always such a pleasure to hear what you the Thalassemia Mukt Bharat this presentation. Like I just said, that it is. We always think that in a corporate setup and in the private practice we would have people being a lot more aware, but it's really sad that even today we see thalassemia patients, thalassemia major. I had a patient very recently whom we checked for the second pregnancy, whose story was very sad, that she had a thalassemia major baby born, and it was only after the baby was born that they realized, the couple, that they were thalassemia minor. And their story had a happy ending, because the baby, underwent a bone marrow transplant, and the daughter was standing right in front of me when they came, for the second baby. And this time, of course, we got the pregnancy tested, and she went on to have a very uneventful pregnancy. So it was a happy ending. But not all people are having happy endings, and it's very often we are seeing even now when patients have gone elsewhere and they're almost in the 5th, 6th month by the time they come to us, and you find that a thalassemia screen hasn't been done in primaries. So that, I think, the awareness has to come to all of us, because we are the people who are dealing with these patients. So it is, I think, gynecologists have a very important role to play in detecting thalassemia. So thank you very
Thank
much.
you.
It was a wonderful presentation.
Thank you. Dr. Harsha Kullar, ma'am, are you there? Dr. Divya?
Divya is here.
Thank you and good evening all. First of all, Dr. Arora, sir, that was a very informative, excellent presentation. Not only that, but your commitment to thalassemia is so inspiring. Thank you once again. And as a private practitioner in Delhi, I would say that in today's era, we just cannot miss these major issues. So hemoglobin electrophoresis or HbA2 estimation, these have become a routine with us, and they should be in case we want to avoid medico-legal implications later. So that is what I want to say. It should become part of our universal screening in a way. Thank you very much, Dr. Vanna.
Thank you. Thank you. So,
Vandana, Dr. Taru is going to take her question.
yes. Ma'am, who is first or the hand first?
First.
Let's sort out the hands first. Dr. Deepshika, your question?
No, thank you, Dr. Arora. Sorry, I was not able to connect. For last 3 years, Madam is really insisting after your talks about reading our these CBC, and we are getting everyone HPLC. Have you observed any incidents which is lowering down in last 3-4 years? Because we heard your talk around 2021 first. So we are getting, almost everyone is getting. So any incidents you are finding which is getting slightly low?
Yes, it is reducing in, I told you, Delhi, we can say some metropolitans, but still we are getting many cases from outskirts. So we need sport to spread your sport to spread this message to colleagues in other parts of India as well, because you must be having some common platforms, colleagues, friends, and tell them that it is a necessity. As you can say, I mean, just before Doctor, I think, told that even to avoid, Dr. Divya, that to avoid medical legal cases, it is still required. So many times patients are coming us and they ask us whether we should go for a swing the gynecologist. We try to, okay, no, it's okay, we'll do something. So patients are, so, you can say, angry, the gynecologist, once they get a thalassemia. I repeatedly asking, please.
Dr. Rashi Verma, kindly mute yourself. Dr. Rashi, please mute yourself.
So it is reducing, but still, new cases are coming.
Dr. Rashi, please mute yourself.
Thank you, sir.
Dr. Rashi, testing.
Thank you, sir.
Kindly mute yourself.
I can ask one question.
Yeah, carry on, Dr. Rekha.
I think that is very nice that Dr. Arora is protecting the gynecologists.
Sir, one of my questions has been answered by Dr. Manchanda, that if my patient of thalassemia has a very low and I want to give FCM or any ferric carboxymaltose or any iron infusion, she said it should not be done. Then if her serum ferritin is very low, 7 or 8, what should I do? Only blood transfusion? Or I have to decide on oral?
Actually, I wanted to interfere, but as you can say, just because you are again respected colleagues, I kept quiet, though I was not happy with the answer, to be very frank. See, thalassemia minor or trait can take as much error as any other pregnant woman. Very simple message.
Even IV iron?
Yes. See, you are giving iron in iron deficiency. The only thing what we ask is, if a person suppose what was happening in the past. See, मैं पहले की बात करूँ, आजकल वो नहीं होता. What we used to do is, hemoglobin is 9 gram, no testing, give iron. That's all. Okay, but the person is going to one physician, then second, then third, and fourth, switching from one doctor to another doctor, and taking iron therapy for 4, 5, 6 months. And person is a thalassemia carrier. His or her hemoglobin may be normal 10 gram or so. It's not increasing and getting good iron. So that was wrong. Then the diagnosis was not made. Now we are usually making the correct diagnosis. So if a person is having an, you can say HB low and RDW high, even with looking at CBC, you can have some idea of whether a person has iron deficiency anemia. So once you suspect, then go for iron studies and ferritin. If ferritin is low, you can easily give FCM, no problem. And if at all ferritin is not very low, you want to give oral, you can continue oral as you are giving to any other pregnant woman. Actually, I wanted to say, I'm sorry I kept quiet at that time. But yes, you.
My second question is, sir, what is the cutoff of A2?
A2, okay. See, though earlier we were saying 3.9 when I started this thalassemia program in 1990 or so, then we see 3.5, but now we are saying from 3 to 3.5, you must go for sequencing, and for 3.5, it is confirmed case.
Okay. And sir,